Good. All right, here we go in 3, 2, 1. What's up, y'all? Welcome to the Sports Medicine Broadcast, episode 130, sudden cardiac arrest. We're talking with Dr. John Higgins. We are recording live at LBJ Hospital here in Houston. So it was a nice rainy trip out here this morning. I'm your host, Jeremy Jackson, sitting right beside me. I got some of my students here. We got Matthew Bravo. We got Shakira Wing, Adela Marquez. They're running the social features, the Twitter and the show notes and things like that. Shakira's got the comments if you're watching live, which we got Bill, Shannon, and Mickey. Thanks for joining us live. If you got comments, post them there for Shakira, and we'll hopefully get them in. And then sitting right across from me, you should be able to see Dr. Mark Knobloch from University of Houston, Masters of Athletic Training. And then, of course, sitting at the main seat there, Dr. John Higgins. So Dr. Higgins, we're going to start it off. Tell us how you became a cardiac specialist.
Well, initially I wanted to be a veterinarian, actually. I had a really cute Dachshund when I was younger called Snoopy. And when Snoopy died, I was like, oh man, I wish I could have done something to prevent that. And then my mom and dad, they got Snoopy 2 and to replace Snoopy 1. And and then anyway, so I kind of had an interest in veterinary studies. And then I was talking to I talked to some people who were veterinarians, and I also talked to some people who were, looking after human beings, the docs. And the veterinarians was saying, don't do it. You got to learn, you've got to learn so many anatomies and physiologies. It's like, the horses, the cows, and they were like, it's crazy, man. Unless you've got like a photographic memory, it's really, really tough. And then I met with the docs and they were like, yeah, it's, you only have to learn one anatomy and physiology. So I thought, yeah, that sounds like a, better idea. But anyway, I did really enjoy the cardiology aspect when I was learning to be a doctor, and particularly listening to heart murmurs and heart sounds and that sort of thing. So that kind of led to me getting really interested in cardiology. And I also like the fact that with the heart, you've got these different tests and where you can actually see things. Mm-hmm. It's not like talking about things, well, we think this is going on, or, doing molecular tests that you can't really see and things. There was a lot of tests that you can kind of do. And that I thought, well, that's cool because I can kind of understand something I can see. I didn't have to use my imagination too much.
So when I was in college, I took general physiology, and that was the coolest class I ever took, because what we actually did was we dissected a live frog. So we cut like the top of the head off and use the pith to make the brain cord. Yes, I know, PETA, whatever. I'm not worried about that because we got to learn somehow. So we put acetylcholine and epinephrine on the heart, and we could watch it like speed up and slow down.
Right.
And then we eventually, since the frog was already dead, we cut the heart out and stuck it in a glass of water, and you could just see it still beating like 10, 20 minutes later. Like, it was the coolest thing to me, just to be able to put that adrenaline on there in the heart and just to see the effects of it. So again, that's my specialty and my experience with the heart. So
yeah, no, I think everyone agrees, here, the heart is definitely the coolest organ in the body. It's both for what it does and also, when you're in love, and stuff,
Oh, yes.
The emotions of the heart. Yeah.
So we're going to kind of jump right in.
Yeah.
So we're, an athletic setting. Everybody's afraid of heart conditions, heart, heat stroke, those kind of things. So what, in this part of the country, what are the main things you would tell somebody to watch out for? We're in a hot environment, high stress, high activity, humid, those kind of things. So what, just to start off, what are we really talking about with sudden cardiac death? What are the main things you look out for when I want listeners to know about, just in general?
Well, I think you bring up a good point, Mark, and what we kind of think is going on with sudden cardiac death in youngsters and young athletes is that there is some kind of predisposing thing that they have themselves. But, a lot of the times we may not necessarily see that unless we get some sort of stress added to that. So I think it's the combination of a stressor, and that stressor might be someone sprinting, really fast, doing some high intensity training episode, or it might be someone who gets really dehydrated, or it might be someone who gets heat, some sort of heat injury. And whatever it is, that stressor coupled with the fact that they have some sort of underlying cardiovascular problem or predisposition, I think that's what leads us to them having the event. So anything you can do, I think there's two parts of this equation, therefore. One is, we want to make sure that those stresses, we minimize the stresses as best we can. And for particularly if we have identified someone who has one of those underlying cardiovascular conditions, or is at some added risk for some reason. So that's kind of the way I like to think about this. And, it's a lot of people just say, hey, it doesn't happen that often. And in fact, I'd like to just mention the American Heart Association in one of their documents described the fact that this sort of a sudden cardiac event, a death event in an athlete occurs, you're just as likely to be struck by lightning. And in fact, someone looked into that, and they got the data from NOAA, and they found that in the United States in the last 10 years, the chance of getting struck by lightning was 1 in 11 million. Mm-hmm. Okay, so the NCAA study over the past 10 years in college, they had a rate of 1 cardiac death in 53,000. So wow, 1 in 11 million is a little bit different to 1 in 53,000. And then if you drill down a little bit more, if you look into NCAA basketball, it's 1 in 15,000. Mm-hmm. And then if you drill down and look at African-American basketball players, you're talking about 1 in 4,000. So I would just like to upfront state that this is not something that is rare. And I'm sure everyone in this room and our listeners has at least heard of a case of someone who has had a sudden cardiac event. Mm-hmm. So I think that it's important to realize, that these things are happening, and the status quo, which is what we are currently doing in most places, which is a history and physical, is not identifying those people who are at high risk. It's just not doing it.
And what I always find interesting is it's a commonly used phrase is the first symptom of underlying heart condition can be death.
Yeah.
they die, and then they do the autopsy. Oh, you have HCM. And I always, HCM, if I remember right, is a prevalence of about 1 in 500.
Exactly.
So you look at Houston, 8,000 athletes, you're talking there's 20 people out there with a condition that could cause immediate death. What do you do? And so, we translates well into one of the things we want to talk about is there's this argument that, or a push, if you want to call it that, for adding EKGs to pre-participation physicals. Additionally, there's been the American side that says, no, it's not cost effective. You put undue stress on an athlete because they'll have a positive EKG. They go for an echo and it becomes negative. So they had a false positive. Mm-hmm. And then you have the Italian, and I kind of quote Italians, it's more maybe the European, you might have a better explanation of that, but they've always been pushing since, I believe, the 1990s. They've had a 90% decrease in sudden cardiac death. So I hate to be anti-American here, but how do the Americans defend that? It sounds like the Italian method, which is EKG screening, is the way to go. What do you, without giving an opinion, how do you defend Americans, or, the traditional stance of no EKGs, we don't need them?
Yeah, well, I think that you brought up a good point, Mark. One of the concerns is that athletes, by the very nature of them having being involved in athletics, have physiological changes, and those can change an ECG. So some athletes can have ECGs that don't look like a normal ECG. And what the concern is that by the American Heart Association is that first of all, it's going to be expensive to do, and that it's going to be really difficult to do. Now, I think both of those things we can counter by saying that you can set up a system, and there are such systems already in this state and in other states where they can do an ECG for about $10 to $20. So think about it. If you go to AMC this weekend with your kids and go to a movie, that's going to be more that's going to be, your movie's going to be a lot more than that, and your popcorn and stuff. So it's not something that is exorbitantly expensive, and the machines are getting better in terms of their algorithms are getting better at differentiating physiologic change from someone with, for example, physiological hypertrophy or athlete's heart from someone that has one of these conditions. And the false positives are not as high as everyone thinks. For example, again, in the NCA 10-year study, they only had a 6% false positive rate, which so essentially, what does that mean? Well, that means that every 100
Real
kids,
quick, you said a 10% false positive?
a 6%.
6%, okay.
6%. So what that means is that, in every 100 kids we screen, 6 of them are going to be flagged on the EKG as abnormal. And what typically happens in this situation, and we've done this in our own study, the Houston Early Age Risk Testing and Screening Study, or HEARTS program, is that those kids will then be seen by a pediatrician or a pediatric cardiologist, and often will get an echocardiogram. And in most cases, within a couple of weeks, basically a visit and or a test, that will be sorted out. Either they have something or they don't. And so I would say that, and then, on the flip side, you're not going to miss those people like the hypertrophic cardiomyopathy cases, which most of the ECGs are going to pick up. Some of the other conditions, including the long QT or the short QT syndrome, the Wolff-Parkinson-White syndrome, as well as some of the other dilated cardiomyopathies and arrhythmogenic right ventricular cardiomyopathy. So a lot of most of the electrical problems that are associated with sudden cardiac death, the ECG is really good for detecting. And what's the cost? The cost is $20 or less per person. And you're going to pick up these kids who have these problems, and there is going to be a little bit of extra cost associated with those false positives. But the funny thing is, when they, the big agencies like the American Heart Association, the American College of Cardiology, saying, it's too expensive, it can't be done, it's going to be, well, they haven't offered an alternative. In fact, I testified at the hearing of Bill 767, which has moved from the committee and is going to be voted on by the House in Austin, Texas today. And they were asked that, well, by the committee members, both the representative for the American Heart Association, for the American Pediatric Association, and the American Electrophysiological Association, they were asked, well, okay, what can we do instead? Give us something. And they were saying, well, we need to do more research. Well, that's what they've been saying for the last 10 plus years. And the research does show that an ECG will add value and will pick up and detect more of those kids. And that's why the International Olympic Committee and the European Society of Cardiology recommend it in their screening, and some other very big European organizations like FIFA who have that up front. Everyone gets an ECG. So if they don't want us to do it, tell us another test we can do for $20 that will detect just as many. It doesn't exist right now.
So you said 6 out of 100 are false positives. How many do they have any statistics on false negatives?
They do, but I don't know if I have those with me. The false negatives, I know they are less than the false positives. I know that, but I don't have the number, how many percent.
Basically, so far, 94% are true positives. I mean, there is something going on. If the false negatives are so low, then the 94% of the time you do have something.
Yeah, when it picks it up. And this is, these were in NCAA AA athletes. So I think that it can be done, and we do have the mechanism to at least make a difference. Now, some of the conditions that are associated with sudden cardiac death, some of those do not show up on an ECG. So we're not going to get all of them. So for example, someone who has Marfan syndrome and or a dilated aortic root coming out of the heart, or an anomalous coronary artery patient, for example, those conditions, those kids will often have normal ECGs. And so we're not going to detect everything. But if you look at what we're detecting with history and physical alone, in most studies, this number is less than 10%. If you add the ECG to that, that number goes up over 50% in most studies. So I think we can at least make a little bit of a difference, identify the people who are in that high risk group, and then at least give them the option, and reduce their risk as much as they can. And also just at least knowing that, I think that person can make, more plans for their future. If obviously if someone has one of these conditions, we think it would be better for them to think of something else, for example, as opposed to being an NBA player, or thinking about Olympic athletics or something like that. If it's something that they have that we can't fix, then maybe they can focus more on a different type of career trajectory.
And that just happened, ironically, at Baylor last year. The guy had Marfan syndrome, was an NBA prospect. And so it actually is a question I have is, how do you deal as a physician? Let's say you look at somebody's test and you see a sudden cardiac death potential condition. How do you address the patient? And their first argument is, I have never had any problems, Doc. You can't tell me I cannot play football anymore. How do you, obviously you say we don't want you to die, but from a psychological, how do you bring them down? Because it's got to be hard to, 1 minute you're playing football, you go in for just your annual exam or your pre-participation physical, and you have to give them the news that you can die at any moment if your heart rate gets triggered, if something triggers you. How do you psychologically deal with that? It's got to be rough.
Yeah, no, that's most of the time. It is a very it's a game changer for these people. A life game changer, as it were. However, after a while, so we first of all, if they flunk a screening, we'll tell them that, okay, something showed up on your electrocardiogram. We're not sure what it means. If it is one of those cases where we're not sure, and all cases, we want to confirm as well. So we'll tell them we need to do some further tests to sort out whether or not this is a normal variant, kind of an athletic change that you have, or whether or not it is one of those true conditions that we know to be associated with sudden cardiac death. And we'll, most of the time, the first time we tell them, it's pretty much, as you mentioned, Mark, just a lot of shock. So they need some time to process it, and for at that point, we just tell them, for now, we wouldn't recommend doing any high intensity type of activities, and until we do some further workup. And then at the next meeting, typically we'll talk to them about the fact that, while this initially may sound like really bad news, if you look at it the way you look at it, if you look at it in light of the fact that, it could be that, this has saved your life, kind of thing. And the other important point, that these screening programs, it's not just about one person, because the majority of these conditions that we detect are hereditary conditions, and the majority of them are autosomal dominant. So that means that in their family, 50% of the children will have those conditions. So identifying one person at risk in a family could potentially save another life in that family. So we put it in a way that, first of all, once we get their diagnosis, if it is something that we can actually fix, and that a fix will then prevent them from having sudden cardiac death. So, for example, Wolff-Parkinson-White syndrome, which is something we've diagnosed in a couple of children in our study. There is an electrophysiological study and procedure which will cure them, and that's it. And once we've done that, they can go back to unrestricted full activity. Now, some of the other conditions, there is not. So hypertrophic cardiomyopathy, for example, which is one of the commoner ones, we can try to prevent sudden cardiac death by not having them perform high intensity activities, as well as reducing the stresses and potentially putting in an ICD or implantable cardioverter defibrillator into those sort of people. And so we can do everything to reduce their risk, but we would tell them that, there is performing these certain activities is associated with, having a sudden cardiac death because of this condition. And so we would counsel them about that and recommend that they avoid that. So
do you get a lot of, and obviously if the parents are there and it's a child's one
Yeah.
thing, do you get people that say, I don't care, I'm fine, I'm going to go continue to play? Or are they usually pretty receptive to, wow, I've got to stop doing what I'm doing? Do you see a difference? Or
we do see some, we've had some cases, for example, that they have, failed a screening and they have refused to have any further workup. So we don't know whether or not that was a false positive or a true positive. So that definitely has happened to us. Most of the cases where we have detected something that is major, they have been, thankful, and the fact that, because many of them, and we discussed the fact that, whether they've heard of people where this has happened, and I can't think of anyone who hasn't. So they get it. They understand that if this happens, look, there are plenty of people that have lost their children, and, we've got this opportunity that we can actually still have our child. So I think the parents that they come on board, eventually, most of them, but there are some that just say, look, he's, he or she has had no symptoms and, has been feeling all right. And this is crazy. And then we never see him again. So.
All right. So in the beginning, Mark talked about the Italians are doing EKGs up front. What is the sports scene like in Italy versus the United States? Because here we have all these club sports, kids are involved in, year-round sports or like 2 sports all year long. So do you have any idea what it's like comparatively, the sports scene there versus here in the States?
Well, the sports scene there, they do have sports. Some of the sports are different. Their largest sport, of course, is soccer. Mm-hmm. So that's kind of played like football is here, with kids. They do have other ball sports. They are into tennis and other sports. So basketball. There are different sports that they play that they can play certainly throughout the year. So that you can have a child who is very active there. But as you guys pointed out before, the interesting thing is that they in Italy and some of the other countries there, and as well as the Federation Internationale for Soccer, or FIFA over there, they are very, very much in favor. In fact, they kind of mandate that you guys, if you're going to play, you need to in certain at a certain level, you need to have screening ECGs. So and that as you guys pointed out, they have made a difference. In that in Italy they've been able to reduce sudden cardiac death by 89%, and because of that and other studies that they have done, they take a very hard stance on doing everything they can to identify and prevent sudden cardiac death. And so FIFA, for example, the Federation for Soccer, they have a 11-step program which covers everything from screening the athlete to what happens for planning when they're playing the game and emergency medical plan. So, and we could go over some of those if you'd like.
You said FIFA, I say FIFA, you say FIFA. They mandate that EKG. So at what they kind of set the standard, and then it trickles down to college and high school and youth leagues. So what's the youngest athlete that may be dealing with a sudden cardiac arrest? So is it like a 10-year-old, upward soccer or youth league soccer, or is it only really when you get to high school and it's really competitive? So at what point, like how far down the line would we need to go?
That's a great question. Well, it depends on who you talk to. So if you talk to the Japanese, they start screening their newborns get a screening ECG. And they screen every about 5 to 10 years because they want to detect, any type of problem. But realistically, most of the sudden cardiac deaths that we see are associated with organized athletic activity. And the data show that people that are doing more organized and certainly professional activity, their level of intensity and stress, etc., is higher. And I think that's why we see more sudden cardiac deaths in that age group. And that age group, by the way, can start as early as 12. You have now a lot of sports where parents have organized leagues and they start them before the kids even get to middle school, or in middle school. So there's not only what the school's doing, but there are these independent leagues that are out there because these, a lot of these parents and the kids love what a particular sport, and they want to not just play, well, they want to, take it to the next level. So in Houston, the sudden cardiac deaths that we've seen in the last 10 years, they tend to be around 13 years of age and up. So I think in terms of a screening program, the program that I'm involved in, the Hearts program, we look at 12-year-olds that's when we start our screening. I think what the bill that, is going through hopefully it will get voted through the House today, 767. They are talking about doing an initial screening on these younger athletes on entry, and then 3 years later. So that follows a little bit what the International Olympic Committee recommends, which is every couple of years. And the reason for that is we know that when kids are growing and they're doing different athletic activities, some of these conditions they may not have expressed themselves early on in their lives, but once they start doing more of these activities and their heart is growing and hypertrophying more, sometimes, for example, hypertrophic cardiomyopathy is a good example. That may not appear until they really start getting more athletic. And that's why I think it is important to have not just one check, maybe a series of checks.
And you, going back to some statistics you threw out, which are very correct. If you want to pinpoint who you're looking at for sudden cardiac death, males are 10-to-1 ratio versus females. But then you got on top of that, African-American males. Is the research starting to show any kind of correlation with something going on that's triggering that, or why this population is higher? Have they found anything? Or is it still just, we really don't know, but we're going to target you for screening tests?
Yeah, I think it's the latter, Mark. I know that there are some associations with African-American or non-Caucasian males and with respect to ECG. One of them is this benign early repolarization change, which they got on their ECGs. Now, there is some evidence. Initially, it was called benign early repolarization because we thought back, decades ago that this was a change that it was a normal variant, as it were. But there's some more research coming out now showing that, in fact, it may not be a benign variant. In fact, some of these people, they have an increased risk of sudden cardiac death. So now that's something that is quite common in African-American athletes. So I don't know whether or not that, and again, the research is going on, but as you correctly pointed out, we know there is a definite spike in this group. And in fact, the NCAA's highest ranking physician, whose name is Brian Hainline, he's their chief medical officer. He, in the fall of this year, plans to recommend ECG screening for at least male basketball players. So I think that we know it's there and it's happening. And so people are starting to make decisions based on that, and including, doing ECGs. I think at the hearing on March the 24th for Bill 767, one person brought up the point that, well, what about the non-athletes? And I think that is an important point, because these conditions, we know that most of them are hereditary. That is, they were born with it. It didn't happen because they decided they liked athletes or, doing athletic activities or not. So one of the points is, well, why not screen them all? And I'm a proponent of that recommendation, because some of these, and our studies, by the way, our heart study has in fact shown that as well, because in our heart study, we screen athletes and non-athletes, and our abnormal detection rate in both groups was almost the same. There was no significant difference. So that is the prevalence of these abnormalities appears similar in both groups. And I think that is something that we need to do. Initially, I think what the first moves and with House Bill 767 is to screen athletes. And I think they're obviously the highest risk group as far as we know, and the statistics bear that out. But there are other children that are running into problems that are, for example, they may be, just having some fun with their friends on weekends and go down, and they may not be a member of the basketball or the football team. So I think that's down the line. I think that's something we need to look into as well, as the high risk. But I agree first, if the thought is that we have limited resources and limited personnel, et cetera, let's focus on these high risk kids to begin. But if we want to really prevent or do our best to prevent all of them, I think we're going to have to expand that screening.
All right. So currently we do mass physicals at this high school. You know how that works?
Yeah. Yes and no, depending on which high school.
Well, all right. So, I mean, roughly the kids come in, we do their height, weight, blood pressure, vision,
Yeah.
and then they go through and visit the 3 or 4 different doctor stations. And the
Yes.
last one at our school, he listens to their heart. And
Yeah.
so with us doing physicals that way, and you're hoping that EKGs get required,
Mhm.
how do you see those two working together? Is this, we're going to do that and then now we have to send them somewhere, or is there going to be an EKG where they, there's a different room where they go and they do that? How do you see that working out?
I think the easiest way to do it is the latter, as you mentioned. That is just set up another station, and that's how I know it's being done. For example, at Crosby High School, where one of the authors of the bill, where his son was who died, they right now they'll have a mass screening day, and they will have the stations set up like that, and the ECG will be added on. The nice thing about ECGs is that most of the current technology has them in a digital format, so they can be remotely transmitted very easily. And so this makes it a lot easier. And also because it is digital, the algorithms can do a very good analysis in terms of helping out what's completely normal and what's abnormal. So that the ECGs, it's fairly easy. It takes about 5 minutes. And as I mentioned, there are a lot of places in Texas that will offer it for, $20 or less. And in fact, there are some places, for example, up in Klein and Spring ISD, they have a group up there that they do them for free for the kids. And what they do is, if they do find a problem, then the kids will see them to get that worked up.
And how does it work? Does the group show up with the equipment and they screen them, or does the coach put the pads on like an AED and just says stick one here and here? How does that work too?
Normally they send out a technician. So it's not a physician who is doing the actual ECG. It's an ECG technician. And they will just go out there with a machine and they'll just hook the kids up. They put on 9 patches, 6 across the chest, 2 one on each arm, and then 1 on the leg. And so the person just lays down. They just take the shirt off, and they put the patches on and the legs, get the ECG, and they can do all of that in under 5 minutes. So it's pretty straightforward. All of the data is then captured on the actual ECG machine. Depending on the machine, it can be wirelessly transferred, or the tech just does the 300 studies or whatever, goes back to their office and then downloads it on their software.
And so are the results instant? Does the machine trigger a problem? If say a kid has a condition, does the machine send an alarm, or they have to wait till they're interpreted? So
they'll get a preliminary.
Okay.
Normally, most ECG machines will give a preliminary, report. So for example, if it just says normal, normal ECG, whatever, then again, it's up to the screening how they want to do it. But oftentimes, for example, in our screenings, if we had a kid, and we also do the echocardiogram on our screenings as well. So we have a 4th step. We do the history, physical, ECG, and the 5-minute echo. But if they go through all of that and all of that looks good, we'll tell them, that they passed. But if there is one part of that screening, whether it be the history, physical, or the ECG, where there's something that just, we're a little bit concerned about, we may say to them, well, look, we need to take a look at this a little bit further and we will get back to you. But it's up to the school how they want to set it up. Some of them want us to give them something right then and there for their parents, whether they, and we normally have 3 categories. Either they passed, it's kind of intermediate where there's something wasn't quite right, but we need to do further testing, and then the third one is if there's something that is a definite, abnormality. So typically that's kind of what we do on our screenings, and we send a thing home with the child to give to their parent, and we also notify the school health personnel, just so that they are aware, of that there is potentially there may be a problem, and that we're, it's being further worked up.
And are they instructed to not participate at that time, or is it become, okay, we see something, we're going to call you in 6 days or a day and schedule? Are they're at that point held out of competition, or what is the recommendation?
Well, most of these ones, what we do is we tell them that no high intensity exercise for now, and no competition until the further workup has been done for these people. Now, if they have something that is where the ECG is not giving it normal, but we suspect it's a normal variant, and they've never had any problems, and feel great and whatever, we'll in most cases, and if they're not doing a high intensity sport, like let's say they're doing something like
Golf.
Right. Yeah, exactly. We do have a couple of those
too, right?
We
all know that argument.
Yeah, no, we screen some of the Rice athletes, and they have a pretty big golf team. So most of the time, we'll tell them, look, we think it's going to be okay, based on the fact that we think it's a normal variant. However, the only way for us to be certain of that is, next week to do your echocardiogram or whatever test we're going to do. And we'll just say, look, hopefully it's another week. We'll get this done. If that clears you, then you'll be good to go. So, and most of them are okay with that. And certainly the coaches, because right. they don't want, and the school, they don't want anything going down.
Right. Right. Yeah. We train them in CPR, but they don't want to have to use it. So,
yeah.
Right,
so you guys have AEDs, right? Yeah.
We have, I think, 5 on our campus. So like one on the nurse, one on the 3rd floor, two in the gym, and one at the football weight room. So,
no, because that's another bill, that was passed sometime back in Texas, because not all states have that, and I think that's a great thing. At least we have a method, methodology if something happens,
right.
know.
So going back to the EKG, you did mention there are some conditions that can't be detected, such as anomalous coronary artery.
Yes.
What can you just talk about, let's say, I know the testing is MRI, correct, is the best way to find those. So what do you do for a kid that has a normal EKG? Is there a motion to, obviously you can't MRI every person from a costs perspective, it's impossible, but there are those other conditions out there, and I'm sure that's used against the EKG argument of requiring it, but how do you answer that? Do we need to look at, is there a second screening we need to start doing to catch these conditions, or is it just, does the EKG seem to be a good enough screening system? Or
well, I think my answer is I would, if I was setting up a screening, and I have actually, well, for our screening we do the ECG and the echocardiogram, both of those, because exactly as you pointed out, Mark, there are certain conditions, like, for example, someone who has a dilated aortic root, that could rupture, or someone that has an anomalous coronary artery, that the ECG will be, or they may have a dilated cardiomyopathy. The ECG may be, normal. However, of those conditions, so if we think of all the conditions that are associated with sudden cardiac death, like hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, Brugada syndrome, the short or long QT syndrome, the Wolff-Parkinson-White syndrome, and most myocarditis and cardiomyopathies are going to have an abnormal ECG. So if we look at, okay, we can get, maybe 6 or 7 out of the 10, we have a chance to identify them by doing the ECG. Okay, there's, 2 or 3 that we're not going to be able to. So do we just say, well, let's not do the ECG because we can't get all 10, and some people say that, so that's their argument, is like, well, if you can't get them all, don't even try. Well, I say, well, a life saved is a life saved. And if you can do that with a low cost test that we have now, and by the way, there is an app now for your iPhone for doing an ECG that one of my friends showed me the other day. So the ECG, it used to be these large machines. Now they're laptop size. Now they're going to even small devices. So I think we're going to see a lot more of with this miniaturization. I think it's going to be a lot easier to do an ECG. On the other side, the echocardiogram machines, they now have a portable echocardiogram machine, which is it's about an inch thick. It's the size of an iPhone, but it's about an inch thick. And they are using that now in fact, there has been some studies where they have used that for screening athletes. So the hope is that they will get some of those other conditions. Now, you are asked about the anomalous coronary arteries, Mark. In fact, MRI is very expensive and it's not very portable. And so, right now, anyway. So, with these children, the studies have shown that you can actually detect their anomalous coronary artery by doing an echocardiography in most patients. So, for example, there was a study where they screened 395 athletes, and about half of them were females, mean age of 19 years of age. And they were able to correctly identify the takeoffs of the left main coronary artery in 99% of the cases, and the right main coronary artery in 96% of the cases. So to summarize that, you can basically say the echocardiogram is extremely good at looking at those coronary arteries. So how we kind of approach that in our study is that we use the 5-minute echo. We have a look to see if we can see those coronary arteries coming off the right places. We also take a quick look at the aortic root to make sure that the aortic root is okay. And then we take a quick look at the heart to see if there's any sign of a cardiomyopathy. And we do all of that in under 5 minutes. So again, rearranging the way you do things. For example, a regular echocardiogram that is done takes an hour, costs $2,000 or even more. And, they're looking at literally 300 or 400 different things. They go through a series of steps. Our echocardiogram takes 5 minutes. It can be done with a portable echo, and it's just looking at about 10 different views. So
sudden cardiac death specific problems.
Exactly. Yeah, so I think you can rearrange the way you do things. So if you were to say, okay, if we want to do screening of athletes with ECGs and echoes, doing the conventional approach, there's no way we could do that. We don't have the people, the personnel, the time, the money, and all of that. But if you just focus on these high value targets that cause the sudden cardiac death, and have your whole mission just focusing on those, I think it can be done. And so I say that first step one is to get the ECGs going, because and this is what House Bill 767 is all about, and hopefully will get voted on by the House today. If 2/3 of the House vote yay, then it'll go forward to the Senate, and then I think this will be a real game changer, because this will be the first time something like this has happened in the United States. So I think that we all know we need to do something different. If we just go with the status quo, we're going to be here next year talking about the deaths that happened between this interview and next interview. Okay, we definitely have to do something different.
All All right, so kind of what I'm understanding is if possible, then what I should do is do my normal physicals and then add on the ECG, which is the electrocardiogram.
Yes.
And the EKG, is that the echocardiogram?
No, ECG and EKG are the same thing.
Okay. That's what I thought. But I just
the reason why that is that it started off a lot in Germany, and they call cardio, they spell it with a K. So,
okay.
So ECG and EKG are the same.
That's what I thought. So then I would do the ECG, and then the next station would ideally be the echo.
Well, in the Higgins universe, yes, I would love to have that as the next station. But in the real world universe of how we are right now, in 2015, I think you would have the ECG. If the ECG is abnormal, then have extra workup. Or if there was something that bothered you on the history and the physical exam. So, for example, let's say the person has an arm span which is greater than their height, which is one of the classic findings of Marfan syndrome. Even though they might have a normal ECG, you might be suspicious, hey, well, maybe they have a dilated aortic root. So maybe you would refer them for an echocardiogram. Or someone might tell you, every time they exercise, they get a chest pressure or chest pain, or just after they exercise. And it only happens, they only get it when they exercise. And, or maybe someone had a brother or sister that died suddenly, and they tell you about that. Well, so it might be that there are some things on the history and physical that are red flags, and even though they have a normal ECG, you are still bothered by something, and you want to get that person further checked out. So I think all parts are important. I'm not saying don't do the history and physical because they're useless. They do add something. And if someone does have a classic physical manifestation, of something like Marfan's disease or something like that, then this might be a great pickup, and you might have saved a life. So I say continue to do those things, but the data is telling us that just those things, the history and physical, if you only do those, you're going to miss most of the kids that are going to have sudden cardiac death. And if you add the ECG, you're going to identify much more of that population than by not doing the ECG.
Gotcha.
So, yeah, and then the echo, you're going to pick up more. It's hard to argue against that.
Yeah, no, it is. It's definitely it comes down to resources and what how the medical community will cope with it. I think if you talk to people and the politicians as well, but if you talk to families and people like you guys, most people are like, okay, look, we know these things are there, let's go get them, and so I think most people who are have children or are working in schools, they want to identify these kids. I mean, it's in their best interest. I think the pushback we're getting is from the special interest groups as well as the insurance companies, and these other groups that are concerned, and changes, scares some people, and I could tell from the people who were talking about this bill down at the Senate, they were scared, they were, whether it be they were scared that it's going to mean changes in the way they do things, changes in their education system, changes for insurance companies, because now they're going to have to pay to have some medical conditions fixed that they didn't have to because the kid just died. They didn't have to pay to get their heart surgery. So change is tough for some of these people, but morally I think it's the right thing to do. And that as a parent, people talk about these statistics all the time. Well, it's only 1 in 4,000, 1 in 5,000, or whatever it is. But it's if it's your kid, that child is your world. It doesn't matter about statistics there. Right. That's 100%.
All right. So at my school, we're probably 95% Hispanic. You talked about the African males being the most high incident. So what are some of the things that I might need to look more at or pay attention to with predominantly Hispanic population?
Again, non-Caucasians have a higher rate of sudden cardiac death. So all groups, regardless of whether it is the African Americans are the top, but the Hispanic Americans are in between. So they are at a higher risk. There are also some things that to be aware of in terms of obesity with Hispanics, depending on the particular area in the population, because we know that overweight or obesity is associated with increased stress on the cardiovascular system. So that's something to be aware of, and even down to maybe what the school's cafeteria is serving. So that's kind of important there, and also just to be cognizant of anyone who tells you that they have any type of cardiac symptoms, whether it be chest pain, palpitations, dizziness, just not feeling right or getting really out of breath more than their colleagues. If there's something that just doesn't seem right, I think it might be worth having them, if they haven't already, at least see a physician as part of their, and just get a, overall checkup. But it sounds like you guys are doing a good screening with your history and the physicals. It's just adding, I think it's really critical to add that ECG to make your screening a lot better.
All right, so then that brings the next question. What if a kid, it's preseason, they're oh, my chest hurts. So how do I know if they're one, just trying to get out of workouts because it's hot and they're lazy and they don't really want to play sports, but they're doing it because they have to, or if it's just that they're out of shape and they're breathing hard, so now that their muscles are cramping and their intercostal muscles or whatever, or that it's something that I need to look further into?
That's a great question. I don't know if I have the answer to that, but I know that if they get checked out and they get an ECG, in most cases, again, that would show a problem. I think if the problem persisted, and
so if we don't have a ECG, so we've done the physical, they're cleared there, but we haven't done the ECG because it hasn't been instated yet. So without any extra workup, what is your thoughts, your opinion on when should I send them?
It will, again, if it's something that they tell you, and as a medical personnel, if someone tells us something and we don't act on it and something untoward happens, then we can get into trouble because they can say, well, why didn't you do something? So I'm sort of thinking more from that kind of.
And I think we think that way too. It's just, you get 2-a-days in football or whatever, soccer, and the first day everybody's, I'm sweaty, I can barely breathe, I can't move, I don't,
Right.
They're lethargic, and he actually asked my next question is, what do you do? Because we want to say everybody's out that has chest pains. You need to sit down, let me look at you, let me take your blood pressure, but you can't. So
Right.
Is there a signal that would trigger us to say, oh, this kid is particular importance other than his physical or his history? Is there anything you see, or is it just really a judgment call?
I mean, most of the time it's just going to be a judgment call. If it's the first day and you have put together a particularly rigorous workout with having them doing lots of aerobic stuff, and then also having them in their doing active rest breaks, by doing sit-ups and other things. So they're not stopping. And if everyone is complaining, and you're not giving them proper water breaks and stuff like that, then probably if it's not just one person, if it was one person and everyone else is okay, and the person, just doesn't look good, it might be that they don't have a good color, or that they are complaining of chest pain, or maybe they're sweating a lot more than everyone else, or so I would say if you're getting multiple complaints, it's probably because of the fact that either they're not, it's early days in training, or that you maybe have got a mismatch between the training and the environmental conditions, and or the rest breaks and the fluids and all that stuff. But if it's one person, and particularly if it's repetitive, if it's happening more than once, but the problem is, as we talked about before, sometimes you only get one warning. And so I think you have to err on the side of safety and have a policy for that at your school as well. That if someone, and I think it is important to have a policy that if someone does have complaints of, chest pain when they're performing PE, this person needs to be seen by a medical physician and receive an ECG or whatever you guys, but do have a written policy and document, make sure you document everything that, and I would say, if it's something that you think is a potentially serious thing, or you're not sure, I don't think that child should return to the field until you've had that further workup. And that can, and I don't mean just your history and physical, I think because you already do that, it sounds like, right?
Right. We do the history and the physical. And, like I said, at the end of it, our doctor, he listens to the heart for any palpitations and then recommends, or requires that they get cleared or have further workups. And so if I have a kid 2 days in a row comes in, my chest is hurting, or every time I exercise, I'm having problems. If I send them to the hospital, is that where they can get the $20 EKG? Or like, if I say, hey, Dr. Higgins, I got this guy, what's going to be my next step there?
I would say if they haven't collapsed or anything like that, and they're not, they don't look like they're in impending danger, and they're basically someone who is not, I would say, a severe case. I think it would be very reasonable that you touch base with their parents. And I mean, I don't know if you guys have a doctor. Some places have a doctor on site, but if not, have them just touch base with the parents and just say, look, this has happened. We're concerned that there may be something else going on. And could you organize, to have them seen by their family physician and, and if there is a policy, I think that should be sent out to the parents too. So they know, okay, under these circumstances, if a child has, compared to other children, if a child seems to be having, more frequent chest pains, palpitations, getting, more severely out of breath or whatever or feeling dizzy or like they're passed out, then we require that they be seen, by their physician and have an electrocardiogram and a note from them saying, that they're okay to return to activity or whatever. I think that you really need to cover yourself because unfortunately, you don't know, that kid might just have one of these underlying cardiac abnormalities. And the worst thing to do, I think, is to just say, like some coaches will just say, oh, I'm going to set an example,
Yeah.
And okay, everyone stay here while, Mikey's going to run 5 times around the oval while we all watch,
Yeah.
Now, are most of the conditions, I know there's, 15 or whatever conditions,
Yeah.
are most of them progressive, or are there some that literally they drop? So my question comes down to, do we have a chance to rescue them if there is an event going on, or are there some where when it happens, it's really too late, other than the AED kind of thing?
Yeah, well, I think the electrical instability or channelopathies that they're born with, Mark, those are just going to happen, and there's nothing. In fact, many times you won't have any warning. It'll just be they go down. However, if you do have an AED on site when they go down, it seems like in most of these cases the common arrhythmias tend to be a faster arrhythmia like ventricular tachycardia. And if you do have an AED there, that is the best way to try to shock them out of that. And there have been good documented cases of these children having events and being shocked out and surviving. So there are other cases too where this has happened and they haven't been able to shock them back, or they don't have an AED there. So the one condition that does tend to sort of change a little bit, and they believe also the risk changes too, is hypertrophic cardiomyopathy. And in that we know that condition, the more they're getting hypertrophy of their heart, so the more athletic heart they kind of are developing, the more the hypertrophic cardiomyopathy seems to come out, the abnormal muscle fibers. So it seems like that in those cases, that those people who are doing more heavy and prolonged endurance kind of athletic type activities, they will be the ones who run into more problem. But again, you can oftentimes the ECG abnormalities will precede the muscle abnormalities as well. So the ECG is still a great test to do on that. But unfortunately, most of these conditions, they are born with them, and most of them they have their whole life. But some of them, they will, while they have the genetic predisposition, they will not show themselves until they start getting into sports. And I think that may be, one of the reasons why we do see, higher rate of sudden cardiac death in sports, but also the fact that, we're putting the body under more stress for most of these kids when we're in sports, as opposed to, someone who's not a big sports person.
There's still a great argument. You got to have an AED on the sidelines at all times.
Oh yeah.
I mean, absolutely.
I think that's a great thing to do. And it's, it's a law too now in Texas. So I think I wish more states would follow that. But I think what we as we talked about at the very start of the broadcast, we have to think about those two parts of the equation, the stress part and then the underlying cardiac problem. And right now we're doing we're getting better on the stress part. We understand heat illnesses a lot better, where we understand about having timed breaks, making sure people are well hydrated. We have great training programs. So we've gotten really good at that. What we haven't gotten good at is identifying these people that have the problem. And that's what we're falling behind. It seems like the rest of the world, Europe, Asia, Australasia, we are behind everyone else. And I think we need to make a difference. And I'm hoping that Texas will kick the ball and start this program. If this gets passed, this will take effect immediately. So this will be, you guys will be doing this on your athletes, in next month.
Yeah, we have physicals later this month. So
and the other thing I would also just recommend to you guys, if you just Google, there are a whole lot of these heart organizations around, both in Houston and in different states, where the Parent Heart Watch, for example, they're a national group. They have pretty much groups in every state. There's several large cardiology groups, within and in and around Houston. So if you just Google, you'll be able to find there are a lot of places where you can get screening with a $20 or under ECG. So where they will basically just come in on the day you are screening, and they will just add that, and that you can be as involved or not involved depending on what you want to do. They can literally come in as an independent contractor and just do all of them, and they will take care of all the paperwork and all of the follow-ups as well.
I'm almost wondering if they're going to start up those little, kind of like they have those MRI shops. I don't know, shops isn't the best word, in a strip mall, and you can go in and get your MRI there. I'm wondering if they're going to see these, especially with this, if they're going to say AED specialist, or not AED, EKG specialist. You go in, you get an EKG June 1st, and you present it, and there's their EKG. I wonder if that will. Yeah. Well,
we've the influenza shot, is a good example of that. I mean, for medical professionals, and also there are some other vaccinations now required in Texas. I think the human papilloma virus, for girls in Texas.
Is big.
Yeah, meningitis. I mean, so those things that are mandated, you will often see at CVS and Walgreens. They'll have those, come in and get those. So I think, yes, I think we'll see that, where they will start, because these machines are so portable, and it's very easy for those groups they already have relationships with most of the doctors' offices around town. So it's very easy for them to have or even a central database. As I said, the EKGs can be read remotely from pretty much anywhere. So I think that will definitely have to come, because so that we can meet this mandate.
And do you, on that remotely, would you? I'm just seeing a scenario where, say, a high school, they do 500 EKGs or whatever, and they ship them off to a doctor. Is reading them as simple as I can look at it and see it, or do I really have to study each one? And could that be a problem where you get, the doctor says, I'll do it for you, and I get 500 to look through, and I start missing things because I start rushing? Or is it really, when you read them, 12 point or whatever it is it really simple to see these conditions? Or I'm wondering about liability. Could you start missing things because there's so many of them to read that you start looking at them and, oh, I missed this. I missed it was off by one little line on the graph, and I missed his heart condition? Or is it pretty clear? What do you see on when you talk about sending them off to be read?
Right. Oh, well, some of them are fairly, first of all, the algorithms that they have now for reading the pediatric ECGs are fairly good, in that the algorithms will 95% of the time or more, they will get it right. So for example, the ECG that is called normal, it will be normal in 95% or more of the cases. If the ECG is abnormal, the algorithms will either call a specific abnormality, like, for example, Brugada syndrome, or significant hypertrophy that we'd see, for example, in hypertrophic cardiomyopathy, or they may say normal variant. So if realistically, if you look at, let's say we're doing 100 ECGs, probably 90% of those would be normal or normal variant. There would be probably 5 to 10% of them that would have something that, and the commonest thing that we've seen in our group is just hypertrophy. And the question then becomes, is this physiological hypertrophy because this person is doing a lot of endurance stuff and that this is just a normal variant, or is this a hypertrophy from hypertrophic cardiomyopathy? So in our study, and also we do screening at Rice University here in town, that's the commonest one that we see that is flagged as abnormal. And the only way to reliably deal with that is to do an echocardiogram. And so typically what we'll do with that is that we'll have the kids come and we'll do, for example, in a screening 100, we'll typically have about 5 that have this situation arise, and they're all athletes, but again, without doing other studies, it can be very difficult to differentiate hypertrophic cardiomyopathy from athlete's heart. So we will do an echocardiogram. The echocardiogram, within about 5 minutes, we'll know which one it is. And so that will be a fairly quick, and in all cases that we've done so far that I've been involved in at Rice, they have all come back as just physiologic athlete's heart. We have not had a hypertrophic cardiomyopathy so far. So and now once that's done, then let's say they come back for their screening next year for their ECG. Now they still get an ECG, and it shows hypertrophy. Now we don't need to. We can now reclassify that hypertrophy as physiologic hypertrophy. So we will change the reading, and we'll just say, instead of abnormal, we'll just say physiological hypertrophy, normal variant, because we already know, we've done the echo on that person last year. So oftentimes with these cases, these quote unquote false positives, they need, one-time test and a one-time seeing someone, and they're good to go for that. In terms of, we now know, okay, as long as they know, and oftentimes we'll give these kids, particularly when they're moving, we'll give them a copy of their ECG as well. Because what we find is that some of these kids will, oftentimes it'll be after we've already done the echocardiogram, they'll say, oh, when I was in, high school, we had an ECG screening, and they told me I had an abnormal ECG, and so
Okay.
we'll give them, oftentimes we'll give these kids a copy of their ECG as well to have for their medical file for the next doctor, so that when they, if they move or if they go to another, playing with another university, that they'll at least know, okay, this is a normal variant.
And so the whole sending them off, they're already flagging. You're not reading 300 independently. You're reading,
right.
You're reading the 12
A very
of those
small
300.
subset, exactly.
Okay. That makes more sense.
Yeah. So
Okay.
the technology, I mean, they'll verify everything. So every ECG will be looked at by at least one physician, every ECG, even the ones
To
that are
make sure it was
normal.
done correctly.
Yeah, just to make sure that there's nothing that, because very rarely the computer algorithm will make a mistake, but in general, the ones that are normal, which are going to be 90% or more, are really normal, and it's only the ones that are flagged. Those are the ones where the doc really has to stop and look and take a look. But I can tell you, most of those cases will then need to go on to get an extra study. For example, if the the ECG machine may call a Brugada syndrome, and the only way really to sort that out is for them to get a special electrophysiological study done by an electrical cardiologist specialist, and they literally they go in there and they try to put them into that sudden cardiac death rhythm. So
Awesome.
they literally they try, and if they are, and because they have catheters and everything like that, they can control everything. They can put you in a rhythm and take you out of it. Like they have the technology to do that. So, and literally, if they can put you into what is considered a dangerous rhythm or one of the early stages of a dangerous rhythm, then that's, as far as they're concerned, that's enough evidence. And then you'll need to get an ICD, implantable cardioverter defibrillator. Now, with that, that will prevent you from having sudden cardiac death. And there are cases of professional athletes who play with an ICD in place. So, but because they know, well, if something does happen, this is going to save their life. So I think it is important for the athletes out there to know that, and for other people thinking about screening, that just because you get diagnosed with something doesn't mean that you're never ever going to be able to do anything. That's the important thing. It might be that depending on the condition, they may not be able to be a basketball player, but they may be able to do something else, which is more lower or intermediate intensity. So that's an important thing. And some of them too, like I said, that are treated with these different implantable things, or some of them are cured with surgery, etc. So it's something that don't be super scared about that. Oh my God, everything has to stop, because in a lot of these cases, we now have the technology to treat them and to or do things to reduce your risk. So it's not game over for everyone, but at least it gives them the opportunity to have a life. And I think that's the, you talked before, Mark, it is an emotional topic, because a lot of the people there who were testifying a couple of weeks ago for this bill were parents who had no idea that their children had a underlying problem and died. There was one amazing story of a cardiologist. So this is a cardiologist in Boston, and his son, he was with his son, who was 16. He played basketball and all that. They were in Haiti on a missionary trip, and there was someone had donated some old ECG machine, which was in a corner, and they, he fired it up. He wanted to check it to see, and he had his son sit down, and he did an ECG on his son, and he had like, OMG, his own son, this is a cardiologist, and his son, who he sees every day of his life, he diagnosed in Haiti with this old machine, and he had when he got back to Boston, he had to go and have surgery at the Massachusetts General Hospital to save his life. And this is a cardiologist. So I'm a cardiologist, so this guy didn't even know there was a problem with his own son.
Right.
So, and this is kind of, one of the best type of doctors who would recognize these problems. So if he didn't, I think it's going to be hard for anyone else to.
Mm-hmm.
Yep. Yeah, because I'm definitely not, like I said, my specialty with the heart was when we cut out the frog's heart. So
yeah.
It's just, it's just like he said, is that we want to take care of the athletes that are complaining of, I'm tired, I just can't, something's not right. And the coach is over here screaming, get him in there, or get her in there, quit being a baby. You hate that, but because you want the kid to participate, and you don't want everybody to have sudden chest pain because he gets to sit out. But yet, like you said, it's like concussions. It's the exact same thing. You hit your head, you're fine, get back in there. Well, how do we know something's not going in there? So we tend to be on the side of, let's get you out, let's do a full evaluation.
Right.
Let's sit you in the shade for a little while, let's see how it goes. And how do we know when, oh, there is something going on versus, because there's no trigger, you know, I wasn't there. I was next door at another school when a kid was stretching before the first day of two-a-days in 2008. He went down and they had to use an AED on him. And there's just, it's not even watch him during high stress physical activity. He was doing nothing. And it's scary. How do you do that? You know, a concussion, there has to be a hit usually. I mean, a whiplash or a hit or something. Then you concentrate. But with AEDs, it's how, you know, the kid's laying over there. Is he unconscious or is he just sleeping before practice? You know, you never know. And so it's a topic for us that's frightening, yet, you know, I hate to say exciting, because then we get to finally do what we're trained to do. Right. But, you know, it's very frustrating because you get these kids that you really want to do a full workup on, but they're the one that they cry wolf all the time. They're always the one hurt. Right. Well, now it's this. And it's just, it'd be nice if there's something we could look for. And it's just, there's not. I mean, clearly.
Right. No, I think until we get some sort of universal screening program, which is comprehensive, I think it's still, it's going to be, you know, a gut call. I would say this much, but, you know, it is important to make sure the kids are hydrated. A lot of kids also, I mean, and drugs is an important thing too. And I'm not talking about, you know, necessarily cocaine and, you know, ecstasy and that sort of stuff. I'm talking about some of the problems we've had with energy drinks, you know, and a lot of kids are using energy drinks prior to athletic activities. And we know that, you know, those have been associated with some issues with heart, you know, with arrhythmias or irregular heart rhythms, with, you know, sudden cardiac death. So check with the kid. And I would say if the kid's complaining of something, you know, do a check yourself, you know, make sure that they haven't told you, you know, for example, they didn't tell you about, you know, they just had a cold and have had a fever, you know, the last couple of days, or they've had diarrhea, you know, and they're having issues with fluids, or they have not been taking their fluids for whatever reason. So make sure that they have not created a stress for themselves, and you know, take them out of the, I think, you know, get them out of the game, get them into a cool area if it's hot, you know, which most of the time it is down in Houston, and make sure they're well hydrated, and that there is nothing else going on that they haven't told you about. But if you know, as you said, Mark, if it's something that is they're telling you about a problem, and, you know, particularly if there's people around, I mean, if they're telling you and there's a witness to that, then if you don't do anything, then, you know, you could run into problems, and you can't, sometimes it can be really difficult, you know, because you might have a kid who has a very low threshold for pain and tells you about everything that you can imagine. And nothing's ever going to happen to him. But then on the other hand, you might have the kid who is, you know, wants to, you know, make his parents proud, does not want to get cut from the team no matter what. And they may be the one that is not telling you about anything. And it's not until they get like almost like an extremis that they'll say, oh, I think there's something wrong. And then they collapse. So you can't say, well, I think, you know, that person's just a hypochondriac, you know, and they're always complaining, so we'll just, you know, leave it alone. I mean, you just don't know these days. So I think without knowing, and also without having the screening, I think you need to err on the side of safety and do the extra workup.
And you brought supplements up, which is, I think, or energy drinks, which is huge, because it's like seems like every other week, some supplement company's been shut down because they found that they have extra ingredients that aren't on the label, which are usually stimulants. And here you have high stress condition in the heart. And I think that's a big part. Is my friend brought this back from wherever they were at, and, you know, I took a couple and it worked. So here, take one. It gave me, you know, boost energy. And well, why? Because your heart's racing. And so if there's one little thing off, then that could be an easy way to trigger it. I think that's a huge point, is, did you take anything before practice? Yeah.
And a lot of people, you know, these days too, you know, are taking different things. You know, they want to get more muscly. You know, they're trying different things. And some of these things are, you know, above board and over the counter stuff. But some of them, you know, they're getting from, you know, unreputable sources, or even ordering over the internet. And I think, but yeah, energy drinks is one, I think, that is really, really common. I mean, well, the statistics are showing that teenagers, you know, 50% or more have at least one of them, you know, each week. So and that's their market. So I brought that up because that's another area of research that we are interested in, and we are involved. We are studying our medical students here at the University of Texas, and what we did is we did a study of their vascular function using a non-invasive ultrasound, looking at the arteries of their arms, and we showed after a single can of 24-ounce can of Monster that in the first 11 that we've analyzed, they had a significant reduction in their ability of their blood to flow in their bodies after and they didn't do anything. I mean, this was just
Tweet that, Matthew. Make sure you tweet that. Go ahead.
This was just at rest. So we and you know, as you know,
I hate to cut you off. Do you know why it was a vasoconstriction, or do you know?
Well, it appears that and this has been shown by other authors, that the energy drinks, via the chemicals they have in them, have an abnormal effect on endothelial function, or they cause endothelial dysfunction acutely.
Wow.
And that means that the arteries are stiffer, they're not opening as well, the platelets and the blood is stickier, so it's more likely to clot and aggregate, and also spasm. And there's been cases, you know, associated with energy drink consumption and sudden cardiac death. And the reason I mention that is that there is a belief, and it sort of fits into this discussion we've been having, that having an energy drink and then combining that with exercise is increasing that stressor part. So if you've got someone who has an underlying cardiovascular condition associated with sudden cardiac death, and they have the energy drink and they're exercising, that's like a double whammy of stress. Mm-hmm. And that may create the perfect storm for sudden cardiac death. And you know, we've seen that in cases around the country where this is the case. So the other problem with energy drinks is, as you pointed out, Mark, they don't tell you a lot of what's in them. They're the transparency. Up in Canada, Health Canada has passed a law. They've changed them from their designation of supplements. Now they are classified under food and beverages. Mm. So Health Canada, because of that, they now have to have the exact amounts of the ingredients listed. The FDA here, unfortunately, we have not done that yet. Most of them are still categorized as supplements, and they have things, you know, guarana. They'll list the caffeine, but they'll also say, you know, an energy blend with guarana, cola beans, you know, all of these other things, which also have caffeine in them. So they actually have more. They not only do they have the artificial caffeine that's been added, they have all of these other sources of caffeine. So put this together with kids that don't drink coffee, you know, every day of the week. I mean, and it's like their body is like, wow, you know, they're lit up. So I would, for those students and people who are listening out there, I would definitely recommend avoid energy drinks right now until we get more research on them, because kids are dying who are drinking energy drinks and exercising.
And you're doing a study, or you published that study?
No, we've published the first 11 reports, and we have 46 total. We are putting together the data on that now.
That's a huge fact. I mean, to know that there's a blood problem after an energy flow problem. I mean, that's huge.
Yeah, exactly. No, I think it's important for people and for people to know that energy drinks are not sports drinks, and they're not like water, you know, and you're safe with water or your sports drinks, you know, like Gatorade and those sort of things. They're okay. But anytime you start doing energy stuff, whether it be the energy drinks or those 5-hour shots, you know, those energy shots, they have even more high levels of caffeine in them than the energy drinks. They have between 70 to 100 or more milligrams of caffeine per mil.
Per mil.
Yeah.
Wow.
The energy shots. So those are really, really something that is concerning. And again, we would like to see those products classified as a food and beverage, so that the companies have to tell us what's in them, and that we would also like warnings and them to be restricted sales to those who are under 18, pregnant women, and those with a caffeine sensitivity, et cetera. So we would like those to be better regulated. I mean, I don't know. Have you guys had issues with the energy drinks at your places?
Yes.
At U of H, I'm sure, I can't speak for athletics, but the standard answer has got to be yes, I'm sure. And I don't mean yes problems, but I'm sure they're in high use because it's like you said, they're marketed. What better, I'm sure high school, but I'm sure 18 to 30-year-old males also is probably a pretty high, and not even that, but just the workplace. You see it on TV. Do you get that? There's a commercial. Do you get that 230 feeling? We'll take an energy shot.
Yes, exactly.
And so it's just, it's marketed to them. I'm sure it's a big deal everywhere for the younger population. I don't drink them not because I'm against them. It's just I haven't needed them, but I'm sure at the high school as well. And because have some Monster, what do you do? Oh, well, we got 2 days now. And so we're going outside. Good. It'll give you some energy. You'll, not to mention dehydration, your heart rate's up and you're just stimulated so much. But
yeah, like I've always said, with a name like Monster, it's got to be good for you, right?
Yeah, exactly.
Now you students are not doing the energy beverages, are you? Good. Okay, Jeremy, your students.
What do you think, Matthew?
Guys?
You just drink a lot of coffee, huh? Like coffee. So good. So they're actually a sports medicine or student athletic trainer, so it's pretty good.
Yeah, no, very, very good.
So we don't stress them out too much on the field, hopefully.
So you guys have to be up so you can help those that are taking the energy shots.
Yeah, that's true. Have you guys on your campuses, have you had rare cases of sudden cardiac death that you've have occurred at your facilities?
U of H had one. It wasn't really. It was more of a trauma injury, and I don't want to say too much because I don't know how much I can say, but I don't know of any true sudden cardiac death. But I'm we're outside of athletics a little bit, but I can get you in contact with somebody that could tell you for sure.
I don't know of any that have occurred on our campus but I think there's been some in the district, in the school district. I know when I went to high school in Dobie, there was a kid that
I remember that one. I was at Lamar when that one happened.
He died. Actually, one of my student athletic trainer friends
and that was a basketball player,
doing
right?
CPR. No, it was during football too.
Was it football?
There was a basketball player at either Beverly Hills or Dobie that did recently, like in the last 10 years.
I was thinking there was a basketball, but this would have been like in 2003 or 4.
Yeah, that happened there. Okay. But no, because I went to, it was probably about 97 when this happened, because I was in high school. I graduated in 99.
Okay.
So, but it came out that it was like drugs related, but I never got the full story. So there's been stuff in the district, but nothing recently that I know of.
Okay.
So about 2003 probably would have been the last thing within the district.
Now, and are you guys ready when House Bill 767 passes?
U of H would be, because they, we have I hate to say, we have the financial ability that we could do easily everybody. Now at a high school, you're the ones that I would say, where's the funding come from? Who pays for it? That kind of thing. That might be a little more of a.
Yeah. So one of the things for us is our school district is partnered with Memorial Hermann, which you are also, I see you have Memorial Hermann ID there. And so it'll be interesting because, here you are with Memorial Hermann pushing us to have this. And then, I hear from some of the athletic trainers that represent Memorial Hermann. They're like, I don't understand how we can't do this, because some of the issues we brought up, who's going to read these? What are we going to do with these false positives? How are we going to get these kids to pay for it? But then even if you mentioned $2,000 for a full EKG workup, I mean, yeah, that's a lot for some people, but I'm thinking my son, if he had a $20 test that said, hey, you probably have a problem, I'm willing to pay $2,000 for his life. And so well, I guess once we have some more information, and if I have that statistics where I can just say, hey, it's only 6 in 100 that have a false negative or a false positive. Right. This is really something we need to look at. This is really something we need to do. This test was $20. Is your kid's life worth $2,000? And, so if for one of those things, it really helps me here understanding the cost and the reality of the situation. Whereas before I was hearing there was like a 20% false positive. Right. Like, yikes, that's terrible. But when you're saying reality, it's not. So. And
I think what will happen too what happens right now is if a doctor suspects a child has a certain condition and has a good reason to suspect that, and then has to do some further testing, then oftentimes if the insurance will actually have to pay for that extra testing. Now they may not pay for the screening test, but if the screening test flags something and says, oh, we think this child has X condition or Y condition, then the extra screening testing and the follow-up visits with the pediatric cardiologist, et cetera, they normally have to be paid. And if this is mandated, they will definitely have to be paid. So I think it's more just getting that organized. And I know Memorial Hermann, we do our screening through Memorial Hermann with the 4-step process, the history, physical, ECG, and echocardiogram. We do that, on a routine basis. So I don't think there will be any problems getting it in. It will be, as we discussed before, it'll be just having someone from Memorial Hermann, a technologist, come out, or probably a couple of technologists come out, set up ECG stations, and have the children get the ECG at the last part of it. And then those will go back to the Central Memorial Hermann. They'll be evaluated and they will give those most likely those 3 categories that we talked about. Pass, no restrictions, fail, restrict, and further workup needed, or indeterminate or borderline, needs an appointment with a cardiologist or something like that. So I know Memorial Hermann has the infrastructure to do that, because we've been doing that with our more advanced, with the 4-step process. This is just the 3-step process. So that I don't think that will be a difficulty in the future. And if this is passed, then it'll have to be done. So someone will have to do it.
So what's the national scene look like this? Because I know some of the people listening live are in like Tennessee. Is Texas the very first one to do something like this in the United States?
Well, Texas, if this passes, this bill, this will be the first time anywhere in the United States where a state law has been passed to mandate ECGs. Now, that it's a good question. The interesting thing is one of the speakers who testified the other week at the hearing was saying that they had at the American Heart Association annual meeting, they had a poll. They were having a discussion about ECG, doing the ECG screening, and they polled their audience, which was about 1,000 members, who were mainly cardiologists, and 60% of them were in favor of doing the ECG. So it looks like the cardiologists want it done, the families want it done, and I think there will be there are already places. I mentioned before about the NCAA medical officer who is going to announce, at least in African American basketball players, that he's going to require that. So there are places right now that are already doing this. Parent Heart Watch, which is a national foundation, they have chapters in every state, and they offer they basically how they work is they do via donations, both locally and nationally. They go out and they do free ECGs and they're doing that in many states. So that's just one example, but in every state there, as I mentioned, for example, up north in Klein and Katy, there's a group of cardiologists up there that they do free ECGs. For example, on this last Saturday, they did 2,000 ECGs on it was a full school screening that they did. So those and they I believe they offer them for $15 or something like that in ECG. So there are groups out there that are already doing it, both here in Texas and around the country. I think my hope is that we'll get this passed in Texas. We'll start doing this. And I think this is one of these situations where the only way to see if it's going to work is to do it. Mm-hmm. People keep saying it can't be done, but I'm saying, well, let's do it. And I mean, we've already done it. Other groups have done it. Small groups are doing it already. Let's just do this thing. Let's get the data. I think it's really going to be important to have as part of this, to make sure we have a good database in Texas. And I think a national registry would be the way of the future, so that we at least know what we can get all of these ECGs in this. We can determine by analysis what are the quote unquote high risk features on these abnormal ECGs. Is benign early repolarization, is that something that we should reclassify now and call it a high risk finding on an ECG? is a normal variant, with can we better kind of define what changes a normal athletic heart has on an ECG? And I think by doing, thousands, millions potentially of ECGs, I think we will be able to get our algorithms and our diagnostic skills much better, so that we'll reduce down, I think, over time, those false positives and false negatives, and will go down, and we will be able to better target and identify those who have the true condition. And why not in Texas, in the great state of Texas? Why do we have to wait? And I kind of have a feeling that we are going to be doing this. I think it was unanimously voted by the committee. I think the House will pass it. We'll see what happens with the Senate, but I think there's enough momentum and enough people out there that say we can't continue on the same path. We got to do something different. Now, maybe it won't work. Maybe it won't work. I don't know, but it's the only thing that we have that looks like it's got the best chance of better identifying, has been shown, in multiple studies, is being done in other parts of the world already. Why don't we give it a try and see what happens? Let the data speak for themselves.
All right. I know you said you need to get to another appointment, so I'm gonna go ahead and we'll close it out there. So, any 1 minute final thoughts, Dr. Knobloch?
No, I think this has been great.
Any final thoughts there?
Well, I would just end with a quote. I like quotes. Former President John F. Kennedy once said, "Some people see things as they are and ask why. I dream things that never were and ask why not." Many in the United States continue to ask why. Why do we need to change the status quo by adding the ECG screening into legislation? But after our discussion today, talking about the benefits of ECG screening in the early detection and prevention, I'm asking the listeners out there, why not? Why not do ECG screening and have the great state of Texas lead the nation in this effort to reduce sudden cardiac death in our young children? So, and it's been great talking to you today too, Mark, as always. Thank you for the assistants. They did an awesome job. And
it's always good to have the expert in the field here.
Exactly.
Well, look, I'm talking to two experts right here. So you guys are on the front lines. So I think it's going to be fun, and we should maybe do a follow-up next year after it, particularly if Bill 767 goes forward. And also too, I mean, if this does pass, we'll definitely get something organized through Memorial Hermann to get you guys screened.
Right. Very cool. Very cool. All right, so that's going to pretty much end it. If you haven't ended it yet, right? Okay, good. So if you want to find out more, sportsmedicinebroadcast.com, that'll have all the links there. So for Jeremy, 3 of my students that got to miss class today get to come on a field trip to hear the expert Dr. Higgins talk. Dr. Mark Knobloch, Dr. John Higgins. That's a wrap.